Thank you. Thank you again to the organizers for the invitation to present. I'm going to discuss now the question of driving pressure versus tidal volume, which has been an important area of controversy and uncertainty in the management of mechanical ventilation and ARDS over the last several years. These are my disclosures. So there's no disagreement that mechanical ventilation is life-saving, and perhaps the best evidence of that comes from the context in which modern mechanical ventilation really was first implemented, or routine positive pressure ventilation was really first implemented, the poliomyelitis epidemic in Copenhagen. And during that epidemic, you can see that during the early course of the epidemic at the Blegdems Hospital, nearly 90% of patients with respiratory involvement from paralytic polio died. And following the implementation of continuous positive pressure ventilation, those mortality numbers dropped dramatically down to about 40% on average in the ensuing months. So ventilation saved lives, but at the same time, we realized that it can do quite a lot of injury. And within 20 years of that original introduction of routine positive pressure ventilation and the development of the modern intensive care unit, it was recognized in a classic experiment by Webb and Tierney that the ventilator could actually cause ARDS. And this figure from their seminal paper published in the 1970s shows isolated lung model subjected to relatively low airway pressures, subjected to high airway pressures with some PEEP, and then high airway pressures with no PEEP at all. And you can see here already some lung edema in comparison to the reference model, and then here marked hemorrhagic necrosis. So it seems that mechanical ventilation can cause lung injury, and this led to the development of a variety of lung protective strategies, most importantly the low tidal volume ventilation strategy. And the benefit of this in terms of mortality was demonstrated in the classic ARDSNet trial published now over 20 years ago. And since that time, low tidal volume ventilation has really become the standard of care for ARDS and for many mechanically ventilated patients more generally. Now, the interesting thing that as you look at this slide actually is that on the left, the lung injury from mechanical ventilation was generated by applying ventilation in terms of pressure. So the injury appeared to be achieved by applying a certain pressure. Whereas on the right, the ventilation strategy was applied in terms of tidal volume. And because of the success of that clinical strategy, clinical management and the risk of ventilator-induced lung injury was assessed primarily in terms of the tidal volume, not the airway pressure. And there was an important background to that development. This experiment here, published by Didier Dreyfus and colleagues in the 1980s, shifted the conversation from a focus on barotrauma to an appreciation of volutrauma, emphasis on the volume being applied to the lung. So they generated high inflation pressure pulmonary edema or ventilator-induced lung injury using three different conditions: a high airway pressure, high tidal volume model, a low airway pressure, high tidal volume model, and a high airway pressure, low tidal volume model. So this model here was generated by simply applying high airway pressures to achieve high tidal volumes. This model here was achieved by applying a negative pressure ventilation to achieve high tidal volume at low airway pressures. And then this model here was achieved by applying straps to the chest wall to increase chest wall elastance, such that with the application of high airway pressure, the tidal volume was still low. And what they demonstrated was that when the tidal volume was high, regardless of whether airway pressure was high or low, you observed evidence of significant lung injury with a marked increase in extravascular lung water, marked increase in lung weight, and in microvascular permeability. And by contrast, if airway pressure was high but tidal volume was kept low, there was no evidence of significant lung injury developing. So this shifted the focus and attention away, and appropriately so, away from airway pressure to a focus on the tidal volume inflating the lung as the major mediator of and target for lung protective ventilation. But when you step back and think about it, a given tidal volume can mean two very different things in two different patients depending on the lung available for ventilation. And the real issue here that you're trying to minimize and avoid whenever you're trying to apply lung protective ventilation is to reduce lung strain. And that's really what volutrauma is about. It's the inflammatory response to excess global and regional lung stress and strain. But lung stress and strain is not just a function of what tidal volume you're applying, it's also how big of a lung you're applying that tidal volume into. And so a patient with a smaller end expiratory lung volume, the so-called baby lung, will experience much greater stress and strain from a given tidal volume than a patient with a larger end expiratory lung volume. And it's been convincingly shown in patients that the degree of lung strain developed during mechanical ventilation is directly correlated to the transpulmonary pressure developed during tidal ventilation. So not the tidal volume per se, but rather the transpulmonary pressure, or the pressure gradient between the inside of the lung and the outside of the lung during tidal ventilation. So really, even though we call it volutrauma, we're really concerned about lung stress and strain, and really that's a pressure issue rather than a volume issue per se, because patients vary widely in how much lung is available for ventilation. And so this conception led to what is called the driving pressure hypothesis. The hypothesis that the main way in which mechanical ventilation injures the lung is by applying excess driving pressure, or the increase in airway pressure during tidal ventilation. And that this was the real mediator of ventilator-induced lung injury, not the tidal volume per se. And this would have important implications for how we set the ventilator, of course, targeting driving pressure rather than tidal volume. And a number of important studies demonstrated that driving pressure is strongly associated with mortality. So this seminal paper by Marcelo Amato and colleagues in the New England Journal demonstrated that there was a clear association between driving pressure and the risk of death, even when tidal volume was relatively similar across groups of patients. You don't see a lot of difference in tidal volume on average between this group and this group, and still see some discrimination in mortality risk in terms of driving pressure. And similarly, my colleague here in Toronto, Martin Erner and colleagues with Eddie Fan, reported a very strong association between dynamic driving pressure and mortality in a large cohort study of patients with hypoxemic respiratory failure. So there's convincing evidence that this marker driving pressure is associated with mortality. But the elephant in the room, the big challenge to interpreting this association is that because driving pressure also reflects the stiffness of the lung, and the stiffness of the lung is clearly reflective of the risk of death, the severity of the ARDS and the risk of death. This would suggest that this association between driving pressure and mortality might simply result from the fact that driving pressure also reflects more severe illness. So patients with higher driving pressure just have more severe ARDS and a worse prognosis. And so it's not so clear that this association is causal or merely a correlation reflecting severity of illness. So to try and test the driving pressure hypothesis, the theory that the real determinant of ventilator-induced lung injury is the driving pressure, and the tidal volume is more a cause of lower or higher driving pressure rather than the other way around. We had to get around this issue of confounding from elastance. And so the way that we tested the hypothesis was to look at the relationship between the effect of tidal volume on mortality in patients with higher elastance and lower elastance. And here's why. So if you take two patients, one of them with higher end expiratory lung volume, and you reduce tidal volume substantially, you'll get less benefit in terms of stress and strain than you would applying the same tidal volume reduction in a patient with a much smaller end expiratory lung volume. So here, the reduction in stress and strain is going to be greater, and therefore the benefit in theory should be greater in comparison to a patient who accrues less reduction in stress and strain. Now, the end expiratory lung volume is strongly or tightly associated with the elastance, and that's really because the mechanics of the lung in ARDS, the degree of reduction in compliance or increase in elastance basically reflects the degree of collapse and consolidation and the size of the baby lung, essentially. So if you have low elastance, that means you've got a large volume of lung available for ventilation. Whereas if you have high elastance, then you have a relatively small volume of lung available for ventilation. So in theory, if the driving high pressure hypothesis is true, then you should see greater mortality benefit from lowering tidal volume in patients with high elastance versus lowering tidal volume in patients with low elastance. And so this is how we set out to test the driving pressure hypothesis. We were fortunate to get access to the data set that Amato and colleagues had used in their original analysis in the New England Journal. 5 randomized trials of lower versus higher tidal volume, of which the ARDSNet trial is by far the largest. And we looked at the relationship between tidal volume, driving pressure, and elastance. These data are presented here. So the red line represents patients randomized to a lower tidal volume strategy, and the blue line represents patients randomized to a higher tidal volume strategy. And of course, you can see the tidal volume is on average much lower in the patients randomized to a lower tidal volume strategy versus a higher tidal volume strategy. But what I'd like you to note here is that if anything, the separation between the arms was, if anything, greater in patients with low elastance versus in the patients with higher elastance. Whereas if you look at driving pressure, the separation between arms in terms of driving pressure is much greater, as you'd expect, in patients with high elastance versus patients with low elastance. So what this sets up is an important way to test the hypothesis, because if lowering tidal volume is the main way that patients are benefited, then the benefit should, if anything, should be greatest in patients with low elastance. Whereas if lowering driving pressure is the main mechanism of benefit, then the benefit, if anything, should be greatest in patients with highest elastance. So this allows us to test this hypothesis. And what we found is a quite striking relationship between the difference in mortality between lower versus higher tidal volume and respiratory system elastance. So at relatively low elastance values, the risk of death was very similar in the lower and higher tidal volume arms. And the probability of absolute risk reduction was approximately 0 in patients with very low elastance. Whereas in patients with high respiratory system elastance, there was progressively greater separation between the arms, such that patients with high elastance had a very large difference in mortality between lower and higher tidal volume. And another way of looking at the same data is to look at the relationship between elastance and the probability of a treatment effect. So each of these curves here represents a different magnitude of treatment benefit. If you look at the red curve, that represents the probability of achieving a greater than 1% absolute risk reduction in mortality. You can see here that when elastance is low, the probability of achieving that benefit is really quite low. But once it exceeds 2 or 2.5, the posterior probability of mortality benefit from lowering tidal volume becomes substantially higher. And again, this is essentially correlated to driving pressure. And what's striking to me is that in the patients with low elastance, the driving pressure in the high tidal volume arm, that is patients being ventilated with 10 to 12 mils per kilo, was on average 15 centimeters of water. And in that group, there was really no association with lower benefit from lowering tidal volume. So this suggests that the driving pressure is useful as a marker of whether or not lowering tidal volume would be beneficial. And when the driving pressure is 15, there doesn't seem to be much evidence to suggest that lowering tidal volume would be particularly beneficial. So from a physiological standpoint, these data suggest that driving pressure rather than tidal volume probably really is the mediator of benefit from lung protective ventilation, and that if driving pressure is 15 centimeters of water or lower, then that probably represents safe mechanical ventilation, assuming the driving pressure is a causal mediator. So the question, of course, then is, well, what do we do with this Dreyfus paper, which shifted us away from airway pressure to tidal volume? Well, the real point of the Dreyfus paper was to demonstrate that it's not airway pressure that matters, but rather the transpulmonary pressure. And so even in this low airway pressure, high tidal volume model, the transpulmonary pressure was, if anything, similar or greater in the low pressure, high tidal volume group. And you can see that the risk of lung injury and development of lung injury is just as severe in this low airway pressure, high tidal volume group, because the transpulmonary pressure is just as enlarged. So this means that really when we're monitoring lung protective ventilation, where we need to be more focused on transpulmonary pressure even than airway pressure per se. Now, when patients are passively ventilated, the transpulmonary pressure swing is tightly correlated to the airway pressure swing. So we can be confident that transpulmonary pressure is appropriately limited if airway pressure is appropriately limited. But once patients start to develop spontaneous breathing, well, then transpulmonary pressure now can be substantially larger than airway pressure. And this is where the risk of lung injury from spontaneous breathing really becomes a concern. There are, of course, multiple experimental studies which quite convincingly demonstrate that spontaneous breathing can cause lung injury. This is the classic experiment from Ted Kolobow's lab, where they injected the sheep model with acetylsalicylic acid in the cisterna magna, generating a massive respiratory drive, which led to the development of lung injury as reflected by hypoxemia and a decrease in compliance. There's also the important data from Takeshi Yoshida and Brian Kavanagh that convincingly demonstrated the injurious potential of injurious levels of spontaneous breathing. And as I said, because spontaneous breathing results in a decrease in pleural pressure, you can have much larger increase in transpulmonary pressure because pleural pressure is being reduced by the respiratory muscle effort. So for example, if you look at these airway pressure tracings here, the positive pressure swing in the airway pressure is only about 10 centimeters of water. But if you have an esophageal balloon in, you can see a negative swing of about 30 centimeters of water. So now the total transpulmonary pressure swing or total transpulmonary driving pressure is about 40 centimeters of water, showing that this lung is being substantially overdistended, even if the airway pressure itself looks reasonably protective. So this is why I want to convince you that we need to focus on the driving transpulmonary pressure rather than the driving airway pressure per se. Now, one of the big challenges to monitoring transpulmonary pressure has been the need for esophageal manometry, but really monitoring has become much easier and simpler in recent years, with a description of a couple of different techniques for assessing respiratory drive and effort in mechanically ventilated patients. So first of all, I monitor airway driving pressure routinely in all mechanically ventilated patients during controlled mechanical ventilation. It's a key target for ensuring that the lung is being adequately protected. During assisted ventilation, you can often successfully measure airway driving pressure by applying an end inspiratory hold. And what you see is that the airway pressure increases at the end of inspiration rather than decreases as you'd expect during passive ventilation. And this increase in plateau pressure represents the combined effects of the ventilator and the patient's respiratory muscles to apply a total airway driving pressure. Another technique that I use routinely is the measurement of POC, or expiratory occlusion pressure. So you simply apply an expiratory hold on the ventilator, and when the patient makes an inspiratory effort, you can see the magnitude of their inspiratory effort against the occluded airway. Giacomo Bolani sometimes refers to this as the iceberg. So normally on the ventilator, you can see the top of the iceberg above the water only, but with the application of the occlusion maneuver, now you can see the underside of the iceberg, and you can see just how much more pressure is being applied to the lungs. So We now have funding in Canada to initiate a clinical trial targeting these measurements of driving pressure and expiratory occlusion pressure to achieve lung protective ventilation in patients with hypoxemic respiratory failure. So I'll wrap up and with the following conclusions. I hope I've been able to convince you that the real target, given the data I presented, for lung protection is the pressure, not the volume per se. And that, in fact, the real target is not the airway pressure, but rather the transpulmonary pressure. And so I think the data that we have suggests that it's crucially important for us at the bedside to be monitoring respiratory mechanics and respiratory effort to minimize the risk of ventilation-induced lung injury. Thank you very much. I'd be happy to take questions.
Three, two, one. We understand that monitoring driving pressure over tidal volume is the conclusion of your talk, in the sense that it might be the mediator or one of the major VILI mediators in ARDS patients. But you also said that in some patients, due to the fact that we cannot exactly know what the transpulmonary pressure is, because there might be an increase of elastance of the chest. If we want to measure transpulmonary driving measure and not airways as such, how would we do that?
That's a very thoughtful question. So I think the scenario that you're describing that's of concern is a scenario where a patient has elevated chest wall elastance, or actually much more commonly, their chest wall pressure volume curve is shifted to the right, so that at a given volume, they have much higher airway pressures. And you are looking at the driving pressure, and it seems to be markedly increased for a given volume. How do you, can we tolerate higher plateau airway pressures in that setting? That's usually the main situation in which we're concerned about an increase in chest wall elastance in passively ventilated patients. And I think the good news is that as long as the airway driving pressure is 15 or less, you can be confident that the transpulmonary pressure is appropriately limited. Because if the chest wall elastance is increased, that means that the transpulmonary driving pressure is even smaller proportion of the airway driving pressure than it normally is. Normally in ARDS, the lung elastance accounts for about 80% of the airway driving pressure, and then the chest wall elastance accounts for about 20% of the airway driving pressure. But if you have an increased chest wall elastance, and now it's say 60-40, well, the actual transpulmonary driving pressure is going to be even lower than it would be if chest wall elastance was relatively lower. So I think with respect to driving pressure specifically, we can be quite confident that when chest wall elastance is elevated, the targeting driving pressure 15 will ensure adequate protection. Now, with respect to the issue of what plateau pressure to accept, because if you have an increase in chest wall elastance or a right shift in the pressure volume curve, then the plateau pressure would be higher, but not necessarily more injurious, because the transpulmonary plateau pressure is not increased. And you know, we just reported in a letter to the Blue in response to an editorial letter about our about our paper in the booth, the data of which I showed you, the analysis showing that provided driving pressure is appropriately limited, the airway plateau pressure doesn't seem to be associated with an increased risk of death. So I think in all patients, the priority should be to ensure a driving pressure that's appropriately limited, also to limit plateau pressure as much as possible. But I think the data pretty convincingly suggests that the dynamic swing in pressure is much more important for lung protection than the static pressure alone.
Thank you so much, Doctor. We have another question from our audience, and they want to know whether the delta in the occlusion pressure could predict or could be correlated to an injurious transpulmonary pressure.
So that's an excellent question. Thank you. I didn't have time to go into detail on the previous work we've done to validate the expiratory occlusion maneuver, but in fact, that's exactly what that pressure swing tells you. So essentially, the pressure swing in the airway during the occlusion reflects the magnitude of the inspiratory effort. And because the mechanics of pressure generation are a bit different during an occlusion, what we've shown is that if you measure the expiratory occlusion pressure, let's say it's 30 centimeters of water, we've shown that if you multiply that by 2/3, that predicts what the esophageal pressure swing would be, which would be therefore about 20 centimeters of water. And when you add that to the airway pressure swing from the ventilator, let's say you're in pressure support of 10, so say 10 centimeters of water, now you have a total of 10 plus 20 centimeters of water of dynamic driving transpulmonary pressure. And we've published papers showing that that's actually quite a reliable and sensitive and specific way of detecting excess driving transpulmonary pressure during spontaneous breathing. So this is a very useful measurement to assess the risk of lung injury during assisted ventilation.
Thank you so much, Doctor. This was the last question. It has been a true honor to be able to listen to you, and we will close this part now, and we will give the floor to Dr. Jean-Louis Teboul for his next presentation. Thank you ever so much.